My name is Brian Rini from Cleveland Clinic Taussig Cancer Institute. I'm at ASCO 2018 in Munich, Germany. And I'm going to talk a little bit about some of the recent happenings in kidney cancer, especially with combination therapy. And I'll focus on 3 studies, 2 of which were presented, at least in part, here at ESMO. The first is the Emotion 151 study that was presented initially at ASCO GU about 6 months ago. Showed a progression-free survival advantage to the combination of atezolizumab and bevacizumab compared to sunitinib, most notably in the PD-L1 positive patients. At this year's ASCO, I presented some follow-up gene expression data from that study. Earlier this year, Dave McDermott published some data in Nature Medicine from the previous phase 2 study that showed some very unique gene signature subpopulations, one characterized by high angiogenesis, one characterized by high immune cell gene expression. And these 2 groups of patients have very different outcomes with the different therapies. That was seen in the phase 2, and then we validated that in the phase 3 with about 820 samples from patients who went on the phase 3 trial. And in brief, showed a few interesting things. One is that sunitinib has an enhanced effect in angiogenesis high versus angiogenesis low tumors, not surprisingly. Atezo-bev has an enhanced effect in patients with a T effector high signature, which is very similar to PD-L1 positive expression by immunohistochemistry. The other interesting findings from that study was characterization of the MSKCC risk groups, which, as you may know, are clinically characterized risk groups. And so what was seen is that favorable risk patients have a more angiogenic profile, high angiogenesis gene scores, whereas intermediate and poor risk patients have a more immune high T effector gene score. And this may explain some of what was seen in the Ipi-Nivo Checkmate 214 study, where favorable risk patients did better with a VEGF inhibitor and intermediate and poor did better with the immune combination. And then lastly, we looked at patients with sarcomatoid tumors, which was about 15% of the population. Those patients, interestingly, are characterized by an angiogenesis low gene signature, but very high T effector gene signatures. And they had especially good outcomes with immune-based therapy. And I've seen some other data sets here at ESMO to suggest that those patients do especially well with immunotherapy, which is welcome news because they otherwise have a very poor prognosis. The other major data set that was presented last evening at the presidential session was the Javelin study, which was a phase 3 of axitinib plus avelumab, so a VEGF TKI and a PD-L1 inhibitor compared to sunitinib standard of care and previously untreated RCC. This was approximately 800 patients and showed a progression-free survival advantage to the combination with a median PFS of 13.8 months and a response rate in the mid-50s. So this is as robust activity as we've really seen in kidney cancer to date, emblematic of activity of these combos in general. There was no overall survival advantage, although the data is relatively immature. And this comes on the heels of a press release last Thursday from Merck about a very similar study with axitinib plus pembrolizumab compared to sunitinib. So very similar designs, but had pembro instead of avelumab. That also showed a progression-free survival advantage. We don't have the full details yet. And very interestingly showed an overall survival advantage at the first interim analysis. So there appears to be some similarities between these regimens, but also maybe some important differences. And so we look forward to that full data set. I think the way that kidney cancer is moving very rapidly is towards immune-based combinations as frontline therapy. There's going to be the immune-immune combinations such as Ipi-Nivo, and then the VEGF immune combinations such as Axi plus Pembro and similar other regimens. And so the next few years we'll sort out which patients may be appropriate for which regimens based on clinical characteristics, gene expression score, other biomarkers. But it's certainly exciting times because we now have the chance to cure more patients with these regimens, these combination regimens, and potentially even combination regimens in sequence that will also be studied over the next few years. Thank you.